Hello everyone, and welcome to our session today, Working with Doctors, Exploring the Myth of Nursogyny. Our presenter is Nicole Nash-Arnold. Nicole is a nursing career coach who helps great nurses transform into respected leaders. She shares her 15 years of experience in both senior and executive health leadership roles to germinate great leadership. Clinically, Nicole has over 10 years perioperative experience before moving into her nurse educator and management roles. Currently, she manages a privately owned emergency department in Brisbane. Nicole has postgraduate qualifications in perioperative nursing and currently a master's in nursing. Nicole is a member of the International Coaches Federation. Nicole, welcome to the microphone.
Thanks very much, Sue. Hello to everybody that's listening. Today we're going to talk about working with doctors, and it's one of those things that we spend the vast majority, for the most part of us, those of us who are nurses, working with doctors, but a lot of us don't actually always crack the ability to work with doctors really, really well. And for the vast majority, we can work with them, but there are some very distinct groups of doctors that we have trouble working with. And there's a lot of reasons for that, but I think the histrionics of our profession has led us to believe that it's a bit like there's some sort of rift, that it's a love-hate relationship, that nurses and it's nurses versus doctors and doctors versus nurses, and it's historically become a very us and them thing. And it's often something that I talk about in terms of it's almost like we've made it about like a form of misogyny, and that's how I came up with the term nursogyny, where doctors, we have this perception that doctors have a feeling like we are different. Sometimes they give the feeling that they might be superior in some way in technical skill or knowledge or status or some way that they feel indifferently. And we often, in the conversations that I have with nurses, that language often comes in a conversation when we talk about the difficult doctors. There's certainly a group of doctors that we work with that that you have no problems with, but ultimately it's all about the patient. And we're trying to get the best for that patient. And you as a nurse stand between that doctor and that nurse. And often when the doctor walks out of that room, then you're the one that's standing there making the whole thing, the glue, work together. And you're the one left to answer the questions and put the pieces together and follow out what needs to happen in terms of that patient's healthcare plan. And that the success of that plan relies heavily on the fact that that nurse and that doctor can communicate well. And if you can communicate well with 75% of your doctors, then it begs the question about what's happening with the last 25% of the doctors that you're working with, and therefore the 25% of those patients. So there's a whole psychology that I open people up to about ways in which you can deal with personalities. So that's what we're going to talk about today. After all, it's ultimately about building a respectful relationship and having a great clinical relationship so that you can get something really wonderful happening for your patient, irrespective of the personality that you're coming up against. So there's a couple of personalities that I think I'll give you an idea about that I think in all of the years when I've spoken to nurses about the difficult doctor, if I was to use that turn of phrase in inverted commas, that they talk about. So the doctor that stalks onto the ward and grabs the nearest RN or student nurse or whoever to come and do the ward rounds, and there's a barrage of questions and it feels laden in sarcasm and superiority and egotistical. They're the guys that nurses often have trouble with. The surgeons, when nurses are in operating theatres, I know that a lot of the doctors that they have trouble with are the ones that don't seem to communicate freely and easily in the same way. There's no chatting, and so you can't build that rapport with them, and therefore that's the way that you build relationships. It's those sorts of doctors that come on and feel the need to talk about only the things that matter to them and nothing else. And, you know, there's a bigger picture. When we're in more senior nursing roles, we often need to get doctors on board with us to be able to work with us in a critical change to the way we're running things on a ward or in an operating theatre or in intensive care or in the community sector. And when you've got that 25% of the doctors that you can't quite get on a Zen level with, then it's going to be difficult because you'll be talking in one way and they'll be talking in another way, and you need to somehow get those aligned. So when we do confront those difficult personalities, a lot of the times we have almost a flight versus fight response, and that conflict grows. And that's what we're going to talk about today to avoid the negative consequences of a relationship that you can't quite get into a Zen place. So what we'll do today is decode the way in which generally people think, and not necessarily doctors, but just the general way that everybody thinks. And then we're going to talk about how doctors think, and then we'll talk about some strategies for each of those as well. Ultimately, it's about decoding this brain of ours. So I'm going to introduce you to a concept called whole brain thinking. There's a guy many years ago by the name of William Herman, and he in his research found that the human brain can be distilled into four main ways of thinking. One of those ways was analytical thinking. Some people thought in sequential thinking. Another group of people thought in an interpersonal style of thinking, and the final group would think about things in an imaginative thinking strategy. After working out that he had those four main ways that the vast majority of the population, if not all, thought in those four ways, then he developed a 120 questionnaire tool that dropped and differentiated people into that tool, and it's called the whole brain thinking method, the Herman Brain Dominance Instrument, HBDI. This particular tool is often compared to other tools that you might have heard of, such as Myers-Briggs, or another one that's called DISC. But ultimately, they all do the same thing. So they drop thinking into a preferred style. And he simplified that even further by dividing those four main ways of thinking into colours. So those analytical people, they're the fact thinkers, they're the blue thinkers. The imaginative thinkers are the ones that think about the future. They're the yellow thinkers. The greens are the sequential thinkers. They think about form. And then finally, those interpersonal thinkers that we talked about before, they're the red. They're the ones that are at the feelings. So if we go into even deeper way to think about each of those four main categories, we'll talk about each of those four categories. Then for each of those four categories, then I'm going to go through, given that it's now August, most of us are doing our tax, then we'll talk about how each of those sequential thinkers think about tax time, how they behave differently. Things that annoy each of those categories, things that each category might say, and things that they might do. So let's take the blues, the analytical thinkers. These guys are logical. They are very firmly fact-based. They only think about the quantitative data, never about the qualitative data. They're usually comfortable with technology, and they know software, and they know computers, and they know everything. They're very technically based. They're very efficient, and they're very realistic. They're very performance orientated. These are the guys who collect data. These are the guys that analyse data. When they're judging the merit of an idea, they base it solely on the merits of the facts. They never think about what could be or should be or would be. They only think about what is here, what is now, and what is past to formulate a view about whether it's a good or a bad idea. They critique and they apply logical reasoning. If we think about what these guys are doing right now when they're doing their tax, they've analysed their tax shelters. They know that research law, they've researched the tax law and they know it absolutely backwards. They've scoured through the ATO's website and they actually know more than they should, from the fact that most of them aren't accountants, for the tax saving options. They've calculated their return and they've got their cost ratio on their investments well and truly formulated. They've estimated all year long. They always get a return, they never pay a refund, and they usually use some fabulously advanced software to calculate all of that. Blues get annoyed by people who use wrong dates, that pull numbers out of the air, use wrong data, just general data, not precise data. They get annoyed by people who mix up the term megabytes for kilobytes. They usually get really annoyed by people who pretend that they have knowledge and then fast find out that they don't. If a blue was to use a particular saying, they'll say things like, all that glitters is gold. They'll say things that those who don't learn from history are doomed to repeat it. They also say things like safety in numbers. If they walked into our ward's tea room to make a cup of coffee, then it's worth considering how they might choose a mug. These particular people walk in and pick a mug. After all, a mug's a mug. It holds water, so it will do the job. The nearest cup is fine. Sequential thinkers. These are the guys who are structured and they are structural. They're very organised and they usually work with very complex or detailed way. They use quality to perfection and they judge things by the quality or the perfection. They're the risk reducers, so they're usually quality and risk managers. They control and they have excellent timing. If they're not quality and risk managers, then they're often the policy makers. They like to set out the very detailed procedures by which people should be following things. They're incredibly sequential. They're great administrators because they always get things done. They're very reliable and they're generally quite neat. These guys follow direction. They perform detailed orientated work and they work through their problems on a step-by-step basis. They're always organised and that's what makes them great implementers. So right now at tax time, these guys rely on the pure experts to do their tax so that they can make sure they are absolutely safe and they're not pushing any boundaries anywhere. They usually use a very conservative and a very well established accountant who has an excellent reputation with many, many, many years of experience. It's August, so what they're doing with tax time is probably getting their return by now because their appointment was on the 1st of July and was well and truly done and dusted. They prepared for their 1st of July appointment by removing all of their receipts from a carefully designed filing system that has been used all through the entire of the year. When Greens get annoyed, they get annoyed by things like mess. They hate slobs. They don't like when things aren't put back where they belong. They don't like people who aren't punctual and they can't stand when people don't RSVP to an invitation. When Greens use sayings, they say things like, cleanliness is next to godliness. Manners maketh the man. And they might say things like, never cry over spilt milk. So if they walked into our tea room and they were choosing a mug to make their coffee, they choose the right cup for the right job. China teacups are for tea and a mug is for coffee. Afternoon teacups and after dinner teacups are very different things. Leaving a coffee ring stain or half-empty cups of coffee lying around will definitely not be tolerated. Next we have the imaginative thinkers. They think about the future. These are the guys that come up with the grand ideas. They're holistic and they're incredibly intuitive. They come up with the most beautiful innovations and concepts, and they're always looking at future trends, what might be and what could be and what should be and won't it be great when. They always come up with a vision and a purpose. They speculate. They're love surprises, they're curious and they play. They look at the big picture and they take initiative. They challenge what people think and they challenge why people think the ways that they do. They're usually visual and they think and speak in metaphors. They approach problems in a creative, out-of-the-box way and always thinking long-term. These guys, though, at tax time, certainly aren't as organised as our blues and greens, that's for sure. They always need more time to get their receipts in order, generally because most of them are lost. They look for ways that they can make this tedious process a little bit of fun. They search high and low for receipts and documents, and when they do finally pull it all together, they toss it in a shoebox. They generally need another copy of their group certificate from their employer, and they scramble for an accountant at the last minute. In July, if it's possible that they make it to July, it's usually later in the year, and then they can't understand why it's hard to get an appointment. They usually have creative ways to minimise their tax burden. Yellows get annoyed by things like people who can't see the parts and not the whole picture. Those people, they feel like they can't see the wood for the trees. They can't stand people who are resistant to change because that for them is where the glory is. They can't stand people not being enthusiastic about an idea, and they cannot stand benchmarking. They're looking back and how the old ways were done. There's no vision in that. Yellows might say things like actions speak louder than words, seeing is believing. And they might say things like change is as good as a holiday. When they walk into our ward tea room and find a cup of tea, their choice is anything goes, provided it's not the same one every day, because that would be boring. They're often in their own home, have got strategically positioned cups staggered around throughout the house so they can always find them, and they definitely have half-finished cups everywhere. The reds, the feelings. These guys are the kinesthetic and the emotional. They're spiritual and the sensory. They're usually the excellent communicators. They have the most beautiful customer service with an incredibly centred sense of community. They love teams and they love relationships. They look for cultures that centre around values, and they usually are very humanistic and expressive. They're often musicians and they make great teachers because they're always supportive. These guys listen. They love to express ideas. They look for personal meaning. They base information gathering on sensory input and group interaction, never numbers. They're the talkers and they're often touchy-feely. At tax time, right now, they're calling up their best friend to ask them if their spouse can be their accountant. They share their worries about what's going to happen with their tax and their tax situation. They ask for advice with everybody that they can find, and they talk about it with everybody about what's going to happen with their tax. They find experts that they're comfortable with. They usually bake and bring a cake to their tax meeting with their accountant. Reds get annoyed by people who are insensitive. They can't stand people that show that they are inconsiderate and that they're uncaring. They can't stand people who are only interested in the answers and the data and the facts and never interested in the feelings and who it's good news for and who it's bad news for when a decision is made. When Reds speak, they often say, home is where the heart is. All is fair in love and war, and to err is human, but to forgive is divine. When they walk into our tea room, they choose a friendly mug, but they've often got their own, and it's always personalised, and it's always beautiful, and it's always lovely, and it's often a gift from a friend or a loved one, and it's often one of those ones that's printed with the photo of their grandchildren or their dog. It's definitely not just a mug. It always means something. So those are the four main categories that we talk about, hence the blues are the facts, and the yellows are the future, and the reds are the feelings, and the greens are the forms. So if we move on now and start talking about what that means for doctors, we first have to take a step back and have a look at that broad view about who doctors are generally speaking. There's a broad generalisation, just like we can generalise about accountants and we can make generalisations about graphic designers and we can make generalisations about architects. You can make the same broad generalisations about doctors and then go into a step deeper. So for example, doctors have some fundamental rational drivers. They are scientists at their very core, after all. So when you're dealing with them, for the most part, each of these guys will want data. And for each of the 4 categories, they want data. They just want it in different and varying forms. They usually prefer individual data rather than whole of hospital data. They want their specific little corner of the world. So they want to know about data that relates to respiratory medicine rather than all of the specialists in the particular hospital that they're working for, because that's what means something to them. They want to make sure that the person delivering the message when they are dealing with someone or dealing with a problem or dealing with a process change on the ward that you work or dealing with a quality process, they want to be able to speak clinician to clinician. And they generally don't respond well when they want to ask questions and they have specific information that they want to know from. Then they often don't respond well if that person is a non-clinical person, because it's uncovered and they uncover that pretty quickly and they don't have a lot of time for that part of the process. They really want that clinical knowledge and that very evidence-based scientific process. Emotional drivers that they have is that doctors want autonomy and respect, and most humans do, but it is quite unique to doctors, and it's very important to remember that when you're dealing with them, that autonomy and respect is what they want. But what they do, as opposed to what they want, is that they heal their patients and they do no harm. So when you're dealing with doctors, it's important when you're dealing with any human being to go to attack a certain problem with the what's in it for them pro forma when you're dealing with it. So when you're trying to ask them to change a practice or getting some sort of engagement in a process, or that you need to solve a problem or manage a patient complaint with them or whatever you need to do with them, you need to come at it with the fact that what they want is autonomy and respect. What they do is they heal and they do no harm. So you need to bring those sorts of thoughts about when you're trying to get them on board and trying to get them engaged into a process. And focus on what matters to them: autonomy, respect, and a quality outcome for either their patient or their practice. Usually it helps to show them documentation, and often more specifically, more broadly than when you're dealing with documentation at a hospital level, about specific examples from their patients. So sometimes it's handy to pull their patients' charts and find an example of what it is that you're trying to ask them to do or what it is that you're trying to ask them to engage with, and use the specific example for, if we did this with Joan Smith, doctor, then this would have been the outcome or this would have been the benefit to her. Always helpful to do it live in a scheduled one-on-one session and make sure that it comes from a clinician and share those examples. So they're the golden rules about what you want to do when you are dealing with doctors. Focus on the what's in it for them. Keep it really simple and educate them on the concept and not the details. They respond really well to templates and tools, and do it live clinician to clinician. So those golden rules are what is important for any doctor. But let's take a look at what it looks like in terms of our HBDI and our whole brain thinking model. I'll give you an example about how this model, this whole brain thinking model, was used for a rep who discovered this thinking after she had a problem. It was from Purdue Pharmacy, which is a pharmaceutical company, who engaged Herman International to come up with a model for them to use for selling to their doctors. And it came about after a sales rep went in to see one of the many GPs, and she trotted out her usual way of presenting material. This particular thinker, this particular rep, was very much a little bit red in her thinking. She had some definite interpersonal and thinkings about the way in which she approached things, but most of all, what her predominant preference was a green thinking. So she liked the structure, and she liked the form, and she liked the step-by-step, and she liked the timing of things and the sequence and the getting things done. So for her style of thinking, walking into a GP's clinic and sitting down and getting out her wares and her little visual aids and her presentation and the brochures and with the diagrams, and then talking from a red perspective about what happened with the patients and how it changed their life. But the doctor in this particular example that she was speaking to was predominantly a blue thinker. And he was completely different to that, red-green thinking, and he just wanted the hardcore clinical facts. And it just didn't work. No matter what she did, she just couldn't quite work out why everything that she did, it just landed flat. And then 25% of the time when she did walk in, it was really, really great. And why that method of communicating with some doctors seemed to sing. And then in the rest of the time, particularly when she dealt with the future thinkers, for example, it just didn't seem to land at all. They're conceptual and they're holistic and they want the big picture, and she was dealing with the minutiae of what was going on and the very, very detailed work. And that's when she approached and came across the HBDI model and realised that she was using a method that was completely in contrast with 2 out of the 4 thinking styles, having some success with the red thinkers and a lot of success with her fellow greens. So she studied this, and for what she dropped all of her doctors that she dealt with in her catchment, based on what she knew about them, she dropped all of them into who she thought might have been a blue, who she thought might have been a future and a yellow, who she thought she knew was going to be a green, and who was going to be the feelings one. And she developed a presentation for each of them, and it was completely different. And all of a sudden, her sales increased. But the thing that mattered to her the most was that after this process, and when she looked back, she found that she very quickly developed a broad credibility with all of her doctors, and the clinical relationship with them changed dramatically. And that was because she used this model. So let's take an example. That's what I showed you before in terms of what facts thinkers look and feel like. So what I might do is give you an example of a doctor that I know, obviously without using any names, that sits with this, and then how you might be able to change your approach to deal with them. So these guys, when they're doctors, they're very data-centric. These guys, when they're doctors, solely talk about the evidence and the research and the textbooks. Actually, they often present you with a textbook or refer you to a textbook. They might have even written one themselves. They'll often talk about their own accomplishments. And they'll often be the very, very problematic blue doctors often have an air of superiority. Perhaps you might even call it sanctimony or egotistical. They have a deep respect for their peers. And when you're dealing with them, the best way to ask for their guidance, their opinion or their strategy is not offer them an opportunity to think in their comfort zone, which is trends and data, and provide them actually with a little bit of a platform for self-promotion. So you might say to them, here's the data for X that we want to implement in this ward to get best outcome for our patients, but you probably already read this research. What do you think about that? I know a doctor who fits perfectly in this. He is a professor, and he always deals in the very, very analytical and the very data-based. When he talks to people, he always gives patients information in terms of the statistics that they use and that they need to have. When nurses speak to him, the worst thing and the worst outcomes they get when they speak to him, now, this particular doctor, is that they start sentences with things like, it's the policy to do this. Or they might say, the hospital needs funding for us to do this, so that's why we're going to do it, with no research or no data behind it. They might start the sentence, if they do use research, with a sentence like, they say, or the research is, without a lot of backing from it. With these guys, you need to coin a marketing phrase. It has to be all killer and no filler when you're dealing with them. It has to be purposeful and it has to be logical, has to be brief, concise and clear. They respond when you're proving your point with demonstrable evidence and data and clinical trials. But you have to be careful because they will want to know the minutiae of those clinical trials so that they can understand whether it was a trial that was worth considering. They appreciate when people demonstrate critical thinking to them, and they actually enjoy a clinical debate and an intelligent debate. And sometimes for nurses that feels like they're being argumentative or patronising, but actually they just want to have a discussion with someone with some intellectual meat. And so they want to really test out whether you know or you think or you believe and why you think that. They really challenge those concepts. So they're not just being difficult, even though sometimes it feels like that. They actually love to just have that debate. And they will look for well-designed studies when you're dealing with them. So that's what you need to do when you're wanting to deal with the blues when they're doctors. All killer, no filler. The future thinkers, they're the guys that are the holistic and the visionaries and the guys that think in big sweeping picture, and they find detail fairly tedious. So they're often very sweeping in the wards and they'll, make generalisations, and they are generally not great at dealing with the detailed stuff. They like conceptual frameworks. These are the guys that love the freedom to treat their patients as they want to treat their patients, and not necessarily, they can't stand standardised practice. They want to be able to do it their way and the way that they believe and that they think is going to get a broad, big picture, great result with the vision that they have, and being boxed into evidence-based practice, although of course they practice by doing that, but boxed into that benchmarking way that is all about what happened when and not about what could be and should be, is a massive, massive problem for them. These guys are the ones that love people who go out of their way. These guys are really egotistical and they're really self-important, and they actually really love to grow knowledge and share knowledge for that greater good. So they're really one of the easier 4 quadrants to tap into, and probably one of the 4 quadrants that nurses don't have a great deal of problem with, because they usually really embrace what you come to them with. If you're coming to them with a change that you want to do with most evidence-based practice is about greater good and what you can achieve and the great possibilities, the grand possibilities that this new process will be, and that if we're going to change this process for the hospital so we can get more funding, so that we can see more patients, so that we can increase our caseload, so that we can have more beds that are available to you. You include that so that the benefits to it. They actually love to hear about the features of what the proposal that you're having to putting forward, but they actually are more interested in the benefits. They're interested in the part of the sentence that follows, so that. And that's the way that you get to these guys. They're always happy to gain knowledge. I'm sure they, like any doctor, are scientists and they want accurate data, but they're actually really hungry for new information and for more information. And they're often wanting suggestions about problems. I have this patient, they might say, and any thoughts on, you might say to them, sorry, I have this patient. Any thoughts on an experience that you've had, how we might be able to improve that? They are incredibly eager to give their vision away because they love change and they love the speculation about what could be and their long-term strategies. they look for the freedom of it all. So it's unlikely that you'll have too much problem with them because they're pretty easy guys to deal with. Same with the feelings, I think. One of the categories in the form of doctors that people have the less problems with. These guys connect on a very personal level, and as nurses I think that's pretty easy to relate to. These are the guys that when they go home they think about their patients and they wonder about them, and they come back and they'll say to you, I was thinking about bed 4 last night and I wonder whether we should do yada yada yada. They're usually easygoing and they're usually approachable, and they're innately human. They really want to collaborate with the team, and it's never a doctor versus nurse thing here. You'll never get that sense from them. When they are dealing with you and they come to you about their patient, they'll often use the term we. Do you think we should do this with that patient in bed 4? I think that'd be really great. What do you think we should do? I think we need to get them organised to have a CT scan in the next day or so. I think they're incredibly collaborative. When they're dealing with patients, they're often giving them options, and again, that we comes into it. We're going to do this to get this outcome. And they often seek the team's opinion when they're doing it. When they deal with patients, it's often a very personal introduction, and their conversations with them are often very personal. And they're always engaging and they're passionate about what they do, and they innately build their relationship with the patients on trust. And they do the same with the clinical team as well. They're always very personal and they build their relationships, clinical relationships based on trust. And they're always thinking about how people feel. So when you're dealing with them, it's usually pretty easy. It's expressive, and, body language and the way in which you speak to them is what is important. They want to see the passion in you, and they want to see that you've got the patient at the core. If you've got anything but the patient at the core, then they will lose interest. They want to know that. Then I've dealt with a doctor who is just like this. She's passionate about the ageing population and what the family should do and how hard it is for them, and her language when she talks about her patients is all about the road that they have travelled and how tough it is. They never have any hidden agendas, and they're always hearing. They always feel like if you talk to them about your situation, that you're truly being heard. The green. These are the second of two categories, I think, from doctors that cause some problems sometimes, and that they can be a little trickier to deal with. These are guys that are the structured and the organised and the complex, and they love the details and the timing and the control and the risk reducers, and they're really, really finite on the way in which they do things. Hence, when they look at research, they pick it apart. So they'll read a research article and say, well, there's only 400 subjects, so it'd be worthwhile considering if there were 1,600 subjects. They're often problematic personalities when doctors, with the difficult version of this particular category, when they're a doctor, in that they are superior and they do have a little bit of egotistical, that perception. They tend to send that message, whether it's perceived or real. And they often have a third eye for doubt, and they can see when you come to them and you're doubting and the way in which you're approaching it. They seem to have a sixth sense for that, and they see it, and it feels to you like they're exploiting that, but really it's their detailed way looking for a flaw in your plan, and therefore why it won't work, and they're risk reducers. So they don't want to, puts their patients on a pathway where there's any skerrick of doubt that it's not going to work. So they seem to be patronising and pick apart, but that's actually just not what they're doing. They're just risk reducers. They often don't respect the multidisciplinary team or anyone in the team, whether it's peers or otherwise, until you've proven yourself, because again, that's part of their risk reducers. They want to know that you've got a brain cell firing and that you're safe to leave their patients with until you've proven yourself. And usually when you have, then you're gold. They tend to challenge everything, and that feels bad. That can feel uncomfortable and difficult and feel like the relationship is flawed or that they're being condescending. But again, it's about that detail that they're seeking. Often they don't like to be challenged themselves. They're very evidence-driven, and they like to have all the information at hand before they make a decision. They'll question the evidence and they'll question your inferences and they'll counter what your arguments say. So when you do come to them and you say, we're going to do this and we've done the research and we've read these articles and the evidence is yada, 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 they'll look for flaws in that. And then when you counter with, well, there were 1,600 groups in these studies and these were the outcomes, they will look for a way in which they can counter, because they're just going to drill down and drill down and drill down and drill down until they feel like they've got every little piece of minutiae and detail that they can get out of it. These guys are often, when you're dealing with them, the time Nazis. They never have much time and they're always flying into the ward, getting everything done. And they can't tolerate waffle. They just cannot tolerate it. So again, they're a little bit like the blues in that it's all killer and no filler, but it's because they want that detail straight off. They love dot points. They love the story and they love to start with what you're trying to achieve. You've got to give them the prize to start with and then give them the information, because they usually don't have the attention span or the interest unless you've got them caught. So they seriously want the very executive summary on things. So the best way is you might start with them is the evidence is this and what's your experience with that, and then they can give you, in that they can give you their concerns and their rebuttals and their challenges and what they don't, and then you can get into a position that you can counter them. They are often very well prepared and have an excellent memory, and the particular guy, the doctor that I have in mind when I think about this category, is incredibly skilled. They're often because they have almost a photographic memory for that detail, and they can execute very, very well and with absolute precision. And they have an incredible passion for thoroughness, and they look for thoroughness in everybody else and don't have a lot of understanding about why no one else has the degree of thoroughness and detail that they do, and they rarely digress from that. So they're the four structures about how you might deal with doctors, and why it's important, I think, to be able to have a look back through each of those categories and think where you most commonly sit. When of those words and descriptors for each of those categories, which of those ones are the ones that sing to you most? And then maybe have a think about, therefore, if you were dealing with anyone in the multidisciplinary team, but most commonly the doctors are the most crucial, that doctor-nurse-patient relationship is probably the most crucial, about when you were presenting information, if you're going to be a REDS, preferential thinker, then you're going to probably present material in a way that what it means, what's good news for the patient, what's bad news for the patient, what it means for their journey. But if you're dealing with the blue, that to them is all filler and no killer, and they're wondering when you're going to get to the point, and they find it incredibly frustrating because they don't have the tolerance for any insight into the way in which you think. And so it's worthwhile having a test about, if I don't present it to a doctor in this particular way, the problem that I'm having and why I think that, a patient's care may be changed to suit that, have a play with providing them with data in that same way. If you're going to give them data and you're going to give them detail and you're going to give them the outcomes, or you're going to give them the features and the benefits, depending on each of the ways in which they think, and see if you have more success, and it might alleviate that feeling like it's doctor versus nurse and that there's a misogyny that goes on, that it's us and them, and actually it's just a different way that you think. It's not an inherently cultural thing that's transversed all the way through our generations of nurses and doctors throughout the years. It's just not thinking about maybe they need the information presented in a different way, and then the patients will have a better outcome. So to that end, if you feel like you need more help or you'd like further information about the way in which you could do that. These slides and the tips for how to deal with each of those categories and more information about those categories are available on my website. So you can go to www.nursemanager.hq, working-with-doctors, and the slides of this, plus some other resources around that I've picked up that will be available for the way in which doctors fundamentally are, will be available for you, and to give you that opportunity to think through about where you are in your thinking preference and where the doctor and how you might be able to formulate a conversation with them.
Nicole, thank you very much for a very interesting presentation. I've not thought about, I mean, obviously as a nurse you understand what people's drivers are, but actually trying to work out the HBDI model and then have the understanding of that model to be able to do your pitch accordingly is a great concept.
It is a pitch, actually. I think describing the information you need to share with doctors is pitching it on your patient's behalf. So that's a really good way of thinking about it.
Because that's what we do. We advocate, don't we?
Absolutely.
I mean, we don't get something done for Mrs. Smith because it reflects on us being a fabulous nurse. We need to get something done for Mrs. Smith because Mrs. Smith's in need of something.
Exactly. I
was actually listening to, sorry.
No, go.
I was listening to an interview with a medical officer today. He's a cardiac surgeon, and you know, he was talking about medicine in general and doctors in specifically, and he said, as a doctor, you have to have. Doctors do have a great ego, and they do need to have a sense of confidence because they couldn't actually do what they do unless they had total belief in themselves. Yes. But with that total belief comes the personality model that you've been able to identify. Yeah,
exactly. I think that's a really absolutely. I think that's a really important thing about when you are advocating for your patient. You have the safety of knowing that you've got a next port of call and not putting yourself in the doctor's shoes as the buck stops with them and they really don't have another port of call, so they have to man up and make that decision and stick with it. It does put doctors and nurses in a different position in the way in which they approach a conversation. So that's an incredibly important point to think about, you know, the fact that they do have that ego. Otherwise, they'd never have the bravery to go, yep, I'm going to cut this person's chest open and stop their heart. It's an incredibly different way, and therefore it brings some of the behaviours that we see.
But the personality model is a brilliant way to be able to look at those behaviours, identify where they fit, and then work out how you can best work with them.
Yeah, it's the ultimate form of manipulation, really.
Yeah, but manipulation for good.
Absolutely, using our manipulation for good and not evil.
Yeah,
and seeing that there, you know, a lot of doctors, I think, despite the fact that from the outside of our community and our profession, I think most people would look at this model and think, well, healthcare professionals would be in the feelings and be reds. And of course, it couldn't be further from the truth, both amongst doctors and nurses. And I think the vast majorities are blue and greens, and therefore that data and so that is so important, but not something that we do to that level, because I don't think that we're generally as green and blue as doctors are. I think we are more of the red thinkers and yellow thinkers.
Look, it's very interesting, and I was going to say that to you. Not only does this assist with working out how to work with doctors, it also shows you how to work with other people within your team. So if you're the clinical nurse and you're having to deal with a number of nurse unit managers, then this also is very good information for you to be able to say, okay, where do they fit? So rather than
Yeah, I think for the clinical nurses that are out there that are even taking up shift leading and team leading for the first time, and being able to drop their team members into each of the categories is really powerful too, so that they can understand that when they can't get that nurse X off to tea, and it's really, really frustrating because they're a green thinker and it's all about time and artsy. I've got my whole shift planned and it's 7 o'clock, I had all nurses off to tea, but she's a feeler and she wants to make sure that her patients are fine and that they're okay and, everything's right, and, that the time doesn't make any difference to her whatsoever. It's about how people feel about it. Then you can start to realise how to motivate them as well.
Look, it's great information to assist you to have the conversation to get what needs to happen to, for the results that that you want. I think it's very clever. I'm going to go to your website and have a look at the additional resources.
Excellent.
And I think HBDI is a very interesting concept. So I thank you very much for bringing it to us today.
My pleasure.
So today we have been listening to Nicole Nash-Arnold, who is a nurse career coach, and her service, Nurse Manager HQ. That link there is where you'll be able to go to, not only to get the slides from today, but some more information about working with doctors or working with any member of the healthcare team using that HBDI model. Very interesting, Nicole. Thank you very much.
Thanks, Sue.
To everyone who's listening, I wish you an absolutely exceptional day as I try and work out where I sit in the personality scale. And I look forward to seeing you online at another webinar very soon. Goodbye.